see 29 students. 29 or 28? 28. I hope you can see my screen. I also hope you can hear me. Yes. So this is our topic today. Neoplastic, esophageal and gastric lesions. We're basically going to cover all the lesions of the stomach, all the lesions of the esophagus, minus the neoplastic, so tumors, minus the tumors. Okay. This is the extent. This is the extent. Of course, most of the time patients will come to you with some presentation. So we have tried to group them according to the typical presentations. For esophagus, they normally either report heartburn, dysphagia. Dysphagia is a difficulty in swallowing. It's normally graded from 1 to 4. 1 being solid, grade 4 meaning nothing is passing, even semi-solid and even liquid food is not passing. So difficulty in swallowing, the term we use is dysphagia. Odynophagia is pain on swallowing. The term we use is odynophagia. But of course, they also have heartburn. They have symptoms of dyspepsia. And sometimes it can present with hematemesis. Gastric lesions tend to present with, again, heartburn. They present with dyspepsia. Of course, they can present with vomiting. They can complicate with the gastric outlet obstruction. They can also present with hematemesis. And on top of that, when it really complicates, they can have perforations. Okay. This is the whole list for esophagus, hiatal hernia, spasms, esophageal webs, Mallory syndrome, Barrett esophagus, achalasia, congenital lesions, esophageal varices, and esophagitis. Okay. And again, for the esophagus, we have grouped them. So if you see a patient presenting typically with obstruction, difficulty in swallowing, then you start thinking of hiatal hernia, you start thinking of spasms, esophageal webs, esophageal rings. It could be some congenital lesions or achalasia. This will present typically with some form of dysphagia. Of course, they can complicate and even give hematemesis or even other features, but typically this group will present with dysphagia, difficulty in swallowing. Yeah. Then there's this group here, these two here that will present typically. Their main presentation will be some vomiting, and that is blood tinged, so hematemesis. If you see a patient presenting predominantly with hematemesis and you think it's an esophageal lesion, we think of two, Mallory syndrome and esophageal varices. And if you have a patient who has dysphagia, they can have dysphagia, they can have heartburn, but they're also presenting with some pain on swallowing. That is odynophagia, or they're having regurgitation. Then think of esophagitis. Most commonly is reflux esophagitis or gastroesophageal reflux disease. I think of infectious esophagitis, and also think of eosinophilic esophagitis. Okay. So that's how we are going to go through the esophageal lesions based on the main symptom. The other distinction will be this is a congenital lesion or this can be an acquired lesion. What I'm showing here is the esophagus and the stomach. This is the normal esophageal gastric junction. And I'm hoping you remember the lining mucosa of the esophagus. What was the lining mucosa of the esophagus? Francis Gatira. Which mucosa lines the esophagus? Francis is not there. Anybody wants to try? Oh, Francis is typing. The lining of the esophagus. Yes, it's stratified squamous epithelium. Good. Non-keratinizing stratified squamous epithelium. Yes, that's what you get in the esophagus. What about the stomach? What about the stomach? If your audio is good enough, now you can speak. Yes, Timothy, good. This is now the glandular epithelium. Glandular epithelium. Yes, glandular epithelium. So this is the junction. This is the junction, and you can even see from this point they look different. This one is dry, is white, it's pale white, not so mucoid. This one is velvety, is mucoid, and it has rugae. This is normally what we call rugae. These are what we call rugae. This is the junction, and this junction has to remain there because this epithelium is suitable, or it is suited to deal with one of the main body's defense mechanism that has to be contained in the stomach. If it goes outside the stomach, it will give you problems, and that's the acid. The acidity here is almost a pH of 1. It is 1,000,000 times higher than what you have in the blood. And you have to contain it there because this is the mucosas we are going to see that can deal with the acidity. This acidity should not come here. If it comes there repeatedly, it means you have to change this mucosa to this type for it to actually survive, and that's a problem. Okay, and that junction has to be there. If this junction moves, that will be another issue. Okay, as we go along, we are going to see that. These are the distinctions of how the stomach is normally defined. This is where the esophagus comes in. So the first part here is called the cardia. This is the fundus. Then the rest of it is the body. Up to here. This is the greater curvature, lesser curvature. This is the antrum. And then the last part is called the pylorus. And now here comes the duodenum. Okay. This distinction is anatomical. This distinction is also histological, as we are going to see. So congenitally, the most common malformation, you can have others. You can have pancreatic tissue in the esophagus. You can have gastric tissue in the esophagus. You can have even sebaceous and what looks like skin tissue in the esophagus. We call them heterotopias. Those are not very common. Most common here seems to be esophageal atresia. Atresia is when an organ is not formed. It's completely stenotic. It's not formed. Okay, a fistula is a connection of two linings. So if you connect the trachea to the esophagus, then we'll call that one a fistula. Or if you connect the anal mucosa to the skin, we'll call that one a fistula. Yes. Or if you connect the intestine to the skin, that's a fistula. A connection of two epithelial lining, we call it a fistula. So in this case, you have a congenital connection between the esophagus and the trachea. And sometimes it's associated with the esophageal atresia, means part of the esophagus is not formed. And this patient very early, normally immediately they start feeding, they actually have problems already. They have regurgitation during feeding because either food is going into the trachea or food is not reaching the stomach. It's remaining in the esophageal atretic esophagus. And so they'll have aspiration because food now goes back into the trachea. They can have suffocation, they can have pneumonia, and of course they'll be vomiting and they'll not be maintaining fluid. They'll have severe fluid and electrolyte imbalances. Yes, let me just show you. This is atresia. You see, at this point the esophagus forms, and then in the middle here there's no esophagus. It could just be a string. Yes, this is atresia, both sides. This one is a fistula. You can see a connection between the esophagus and the trachea. This is a fistula. So food will come in from here and go straight into the trachea. So this is an atresia with a distal fistula. This is a complete atresia. This one is a fistula. Yes, a fistula with no atresia. So these are the different types of tracheoesophageal fistula. Yes, here is a better term. Yes, so the normal one, you can see how the esophagus passes, and the trachea is also just going on its own. So the type A, you have an isolated esophageal atresia. So this is the proximal esophagus, atretic there. It's missing with a distal esophagus. This is called type A. This is called type B. There's a proximal esophageal fistula with an atresia distally. That's a type B. Then this is a type C. You have a proximal atresia with a distal fistula. This is the type C. This is the most common. Yeah, this is the most common. Like 80%, 80 to 90% of all the types will be this type, will be the type C. Then this one you can see just have fistulas, both distally and proximally. And this one you just have with an intervening atresia. This one here, there's no atresia. It's just an isolated fistula. That is the type E. And they've said type C is the most, but all of these will present with the symptoms we have mentioned, the aspiration, the suffocation, the pneumonia, and of course they'll be vomiting, they'll not be retaining fluid. This is esophageal atresia and tracheoesophageal fistula. Another congenital or mechanical disorder, we call them esophageal webs. These are just web-like protrusions of the esophageal mucosa into the lumen. It means the mucosa goes into the lumen and can partially block the lumen. And what you get is a dysphagia that is non-progressive. If you have a progressive dysphagia in our country, a patient, especially somebody 30 years, 29, going upward with a progressive dysphagia. Progressive dysphagia means initially they could could have difficulties only in swallowing solid food. Then it's getting worse and worse that even porridge is not passing through. Then we say that's a progressive dysphagia. If you have progressive dysphagia in our country, whether it's a man or a woman, you think of esophageal carcinoma. It's the one that typically gives you that. But this non-progressive one could be these other benign lesions. Yes, so this patient will present with the dysphagia that is non-progressive. Okay. I've put in this one here because we don't have it so much nowadays, but it's still there. It's called Plummer-Vinson syndrome. This one is normally related to iron deficiency anemia. So a patient has iron deficiency anemia, they have esophageal webs, Normally, women they'll have glossitis. Glossitis is inflammation of the tongue. Chelosis is inflammation of the lips, especially the angles. Okay, and of course, this one has been shown to have an increased risk of carcinoma. It's called Plummer-Vinson syndrome, related to iron deficiency anemia. They are normally circumferential, means they cover part of the lumen, and they are composed of fibrovascular connective tissue, and they have an overlying epithelium. We have an example of a web, and I'll show you. I think I have it somewhere on top there. Esophageal rings are like webs, but now here you can see this one only had a mucosa. They just had some connective tissue and epithelium, but the rings are more thicker. They are circumferential, they are thicker, they have a mucosa, they have a submucosa, and sometimes they even have a muscularis propria. It's like the wall of the esophagus has prolapsed into the lumen. If you see them above the gastroesophageal junction, they're called A-rings, and they'll have squamous epithelium. If you see them at the gastroesophageal junction, they're called B-rings, and they'll have a simple columnar epithelium, the gastric type mucosa. So esophageal rings are just like the webs, but they have a thicker wall. They'll have a mucosa, they have a submucosa, and sometimes they have a muscularis propria. It's like the wall has just caved into the wall has grown into the lumen. That will be a ring. My pictures. Yes, this is a ring. Yes. Of course, this patient has another problem that we are going to see, but this is what we call a ring, lower esophageal ring. And of course, now this one will give you. This is how it's going to appear on imaging. This is called a barium swallow. A barium swallow, you're given something thick like porridge that has contrast. So as they take pictures, they'll see how this material flows, and you can see a ring here going into the lumen. Yes, but of course, this stomach, this is another abnormality here that we are going to see. It looks like part of the stomach has slid into past the diaphragm. We're going to come to that. What we're showing here is a lower esophageal ring. Lower esophageal ring. But there's also a hernia here. That one we'll see later. Spasm is basically when there's irregular or a confused peristalsis. Okay. A peristalsis or contractions that are short or long-lived or focal or diffuse that are not coordinated. So basically what you have here is a functional obstruction. It means the muscle wall is okay, but the muscle wall is not coordinating the peristalsis. So in fact, the food remains. You feel like you can't swallow. You have functional obstruction, and sometimes because of that excessive intraluminal pressure, you can have diverticular. That's all I'm going to say about spasms. Basically, discoordinated spasmodic contractions of the esophagus that does not lead to effective peristalsis. So this is more of a functional obstruction, not anatomic obstruction. Okay. A diverticular now is when the wall collapses outside. Yes, there's a weakening in the wall of the esophagus, and the esophagus produces a pouch. And this pouch can have one layer, can be made of a mucosa, can be made of the submucosa, can be made of the muscularis propria. And they can be large enough to accumulate even food. Then the food remains, instead of food going into the stomach, food enters into another hole. A pouch is like another hole in there that's arising from the esophagus and forming a pouch. Okay, when they're above the esophageal sphincter, we call them Zenka diverticulum. When they are just at the midpoint, we call them a traction diverticulum. When they are just above the diaphragm or just above the lower esophageal sphincter, we call them epiphrenic. Let me just show you the pictures. This is the this should be the cricoid cartilage, and this is the trachea. This is the esophagus, and you can see something has formed like a pouch. Yes, has formed like a pouch. Yeah, so this will be a Zenka diverticulum. The wall has weakened, and you can this one can actually contain a lot of food inside there. And even if you look at it from if you're doing endoscopy, you will see this is the lumen of the esophagus, and then the esophagus seems to be having another lumen there. This is where now food is actually going through. Okay, the traction one is in the mid esophagus. You can see another one here. There's a pouch over there. Okay, so this is a diverticulum, and you can see this is the lumen, and there is another lumen formed, so that food is now tracking into this. This is the pouch here. You're looking at it from inside, and again, this is the diaphragm, and you can see there's another pouch here. Yes, this is just above the diaphragm, so we'll call it epiphrenic. Yes, this is a diverticulum, and this is an opened one. I hope you can see this is an esophagus that has been opened, and you can see there's a hole there, so food will be passing into here and most likely accumulating behind there. This is a diverticulum. You will find diverticulum even when you discuss the colon. We also find diverticulum in the small intestine. Okay. Achalasia, again, this will give you typically dysphagia, but it can progress with, it can give you other symptoms. Achalasia is basically the lower esophageal sphincter does not relax. When food is supposed to be passed from the esophagus to the stomach. Okay? Food is coming from the mouth. You relax the upper esophageal sphincter. Food passes. At that point, you have closed the lower esophageal sphincter, such that a gastric content does not pass back into the stomach, into the esophagus. When food nears the stomach, you open the lower esophageal sphincter, and the food will pass. Now, in this case, there's a problem with coordination of the muscle and the sphincters. In that now, you have incomplete relaxation of the lower esophageal sphincter with increased lower esophageal sphincter tone, and the esophagus is not giving you strong peristalsis. So in short, you close the door, in this case the lower esophageal sphincter, but you don't have enough power to push food through that closed door, so that food now remains in the esophagus. So a triad of incomplete relaxation of the lower esophageal sphincter, increased lower esophageal sphincter tone, and then esophageal peristalsis. That is achalasia, or we call cardiospasm or megaesophagus, because food will remain in the esophagus and the esophagus will become larger. Typically, what you are going to see with what we call Hirschsprung's disease. Hirschsprung's disease. Okay. So the problem here normally is there is a failure of the neurons with impaired lower esophageal sphincter relaxation. So the lower esophageal sphincter cannot relax. It could be idiopathic, means we don't know the cause very well, but it could be related to the neurons being abnormal, or the failure of the neurons to form, or sometimes you get a secondary autoimmune attack, a T-cell mediated to the neurons. Okay. Or achalasia can also be caused by Chagas disease. You have done Year three, you must have done parasitology. You have done parasitology.
Yes, we have done.
Okay. So Chagas disease is which one? Chagas disease? Chagas disease is the South
What I
American.
remember is
Yes, yes,
what I
Gitav.
remember. Yes, what I remember is a protozoan caused disease by Trypanosoma cruzi.
Yes. Yes, Gitav. This is Trypanosoma cruzi. This is the South American trypanosomiasis. And it causes damage to the neurons of the heart. It also causes damage to the neurons or on the in the esophagus. You can also have what we call motor neuron disease. Motor neuron disease. Even diabetes can cause some neuropathy. Okay, we see this also with the Down syndrome. We can see this with malignancy. We can see with amyloidosis and also disorders we call sarcoidosis. Sarcoidosis is basically an idiopathic systemic granulomatous lesion. You can also have this syndrome called Algrove syndrome. This is an inherited form of achalasia. They don't produce uh, tears, so no lacrimal glands. On top of that, they have adrenal insufficiency. But what you should remember is that in this case, the lower esophageal sphincter does not relax, and the esophageal muscles are not strong enough to push the food through. So food remains in the esophagus. You have some form of obstruction. You have progressive dysphagia. Yes, and because there's a lot of food remaining in the in the esophagus, with the weakening of the esophagus, the proximal esophagus normally dilates. So you have a gross dilatation of the esophagus proximal to the LES, and on the barium swallow, you see what's called a bad big sign. I'll show you what you mean by a bad big sign. This can give you esophageal carcinoma because again you're having ulcerations. You can have ulceration, you can have gastroesophageal reflux, you can have Barrett esophagus, you can have Barrett infection, Candida infection, you can have lower esophageal diverticula, like the ones you have shown. You can have ulceration, peptic ulceration, you can have even a stricture, and all these uh, inflammatory and metaplastic lesions can progress to esophageal carcinoma. This is the bad big sign. So this is the lower esophageal sphincter. It's very tight, so food is not passing through. So you're given this is the barium swallow. So you can see here there's dilatation of the proximal esophagus, which is actually markedly dilated, and then it comes here. It looks like the beak of a bird, if that is the head of the bird, and then this is the eye of the bird. This is what we call the bad beak sign. And when it's opened, this is the tongue, this is the epiglottis, this is the which should be the normal esophagus. You can see this is a markedly enlarged esophagus. Yes, this is a megaesophagus. And that's why the term at the beginning we say it's called megaesophagus. Because of that proximal dilatation of the esophagus above the lower esophageal sphincter. So the ones we have discussed, typically you'll have some form of obstruction. They'll present with a dysphagia. The next two will typically present with bleeding. You'll have some form of hematemesis. And number one is called Mallory syndrome. And number two is called esophageal varices. And what's Mallory syndrome? You have lacerations at the gastroesophageal junction due to severe prolonged vomiting. So you're vomiting again and again and again. And the way normally vomiting is the reverse of peristalsis. And what happens is that you increase pressure in the gastric, in the stomach, and then you open the lower esophageal sphincter and food passes back. But if that is prolonged and that coordination is also not there, then what you end up with is you are now forcing food backward through a tightened esophagus, and this will cause lacerations. We see this mainly with alcoholism, especially guys who drink a lot of alcohol and then they start vomiting and then they are vomiting. And the history normally is he was vomiting non-bile stain, non-bloody vomit. Yes. Then eventually the vomit has turned bloody. So there's always that retching, the retching, prolonged vomiting. Then now you have tears, then you have bleeding. And it's a very common cause of upper GI bleeding, upper GI bleeding. Yes. 10% of upper GI bleeding could be related to Mallory Weiss syndrome. It's very common with alcoholism. And grossly, what you see linear lacerations of the gastroesophageal junction. The main complication is called Bohave syndrome. Bohave syndrome or Bohave syndrome is when the esophagus just ruptures, complete transmural esophageal rupture. And if that occurs, then most of the esophageal content and even the gastric content is poured into the mediastinum. You have a chemical mediastinitis, almost always fatal. I've been unlucky enough to do some autopsies, actually 2 of patients who died like that. Yes, and the history is they were vomiting, and then after a long bout of vomiting, the vomit has changed to blood stain, and then they had a sudden major vomiting, and then they just collapsed, they just worsened. Okay, and when you open, you find the whole pleural cavity is just full of food content. That is a Bohave syndrome. That could be a complication for Mallory Weiss tear. These are the tears. We say that the gastroesophageal junction. Yes, these are the tears at the gastroesophageal junction. This is the gastroesophageal junction there, just above the gastroesophageal junction. And if you remember again, this is the stomach. Stomach normally is velvety, soft. The esophagus tends to be dry and a bit hard. And you can see this is the gastroesophageal junction there. And then you can see a long tear over there. Yes, this is a Mallory Weiss tear. Typically presents with bleeding. Okay, and normally how do we treat this? We do what is called a balloon tamponade. You push a balloon and then you inflate it, and then it puts pressure on the tears until they heal. At the same time, you have something to suck out the blood that is there. Okay, this is normally called balloon tamponade. We use this in emergency setting again also for the next lesion we call varices. This one will present with bleeding, typically bleeding. The next lesion that will present typically with bleeding is called esophageal varices. In the esophageal varices are basically dilated submucosal veins in the lower third of the esophagus, usually secondary to portal hypertension. Yes, portal hypertension, anything that's going to cause portal hypertension can give you esophageal varices. You're going to discuss portal hypertension much better when you come to the liver. But basically, we are saying is that you have a shunting. The portal system takes blood to the liver. Then you have the systemic circulation. But there are some areas where that portal system there's an anastomosis with the systemic circulation. So if you block the portal circulation, blood is shunted the systemic circulation. And there are some areas where you normally have those anastomoses. And the anastomosis, you see them in the esophagus, you see them around the umbilicus, and you also see them in the rectum. So when you have an increased pressure in the liver system, like when you have cirrhosis, or when you have hepatic schistosomiasis, then you shunt blood to the systemic anastomosis. And the systemic anastomosis normally is in the esophagus, is around the umbilicus, and also around the rectum. And that's how you get the varices in the esophagus, and you get hemorrhoids in the rectum. And esophageal varices are very typical with cirrhosis, especially alcoholic cirrhosis. And also in our setting, hepatic schistosomiasis. Which schistosoma will give you hepatic schistosomiasis? You said you have done parasitology. Which one? Which species? Joy Nyavira. Which schistosoma will give you hepatic schistosomiasis? Or how many species of schistosoma do you know? You can speak. You are unmuted. Your microphones have been. They're okay now. You can speak if you have good audio. Which species of schistosoma will give you hepatic schistosomiasis?
Schistosoma manzoni, but also we have
Yes.
cases of schistosoma japonica.
Yes. But in our setting, as Gita has put it, Mansoni. Okay, so you have a patient from Mwea, Machakos, and those other areas, and Kano, and they have this bleeding, they are vomiting blood, they are bleeding a lot. You should suspect hepatic schistosomiasis. But again, the typical characteristic normally is alcohol, and this is what they normally have a significant bleeding. They can be asymptomatic, or they can have massive hematemesis when they rupture, and the rupture can be caused by erosion, can be caused by increased pressure, can also be caused by vomiting. And you see now the alcoholism giving you vomiting, and then the alcoholism giving you cirrhosis. And prognosis normally is very bad. They die a lot once they start the bleeding. So 50% will die with the first bleed because it's massive. And then even if it recurs, another 50 will still die the same way. So either way, it's a very difficult situation to manage, especially when decompensated cirrhosis develops. And the problem is that as you are going to discuss cirrhosis, once you start the bleeding will worsen the cirrhosis. Sorry, I don't know whether I have a better picture, but this is against the stomach. There's some ulcerations here. There's some ulcerations here. There's some ulcerations here. This is a micrograph. This is the keratinizing squamous epithelium, and around here there are some dilated vascular channels. Yes, they are markedly dilated. And you can see this one, there's a disruption of the epithelium, so this one has ulcerated, and most likely this one has bled. And if you look down here, yes, now you can confirm this is a vessel, yes, and this is the keratinizing squamous epithelium, and it's actually markedly dilated vessel. This one can again rupture if there's a erosion. If this one ruptures, you just have blood pouring out. Here's a better one. This is endoscopy, and you can see markedly tortuous submucosal. It looks like a snake here. Yes, this is normal. This one is where the blood vessel is. And if this one ruptures, normally veins normally are thin walled. They are not very able to contain blood if they are injured. Yes, so if this one ruptures here, you have massive hematemesis. Okay? That is a esophageal varices. So those two varices and Mallory waste will give you more of a bleeding. Now, there are others that will give you some heartburn or rhinophagia or regurgitation. So you can have either chemical esophagitis, it's infectious esophagitis, reflux esophagitis. This is the most common cause of esophagitis. And then this reflux esophagitis will lead to Barrett esophagus, and Barrett esophagus can now lead to adenocarcinoma. This one normally heartburn, rhinophagia, and some regurgitation. The infectious one represent mainly with rhinophagia, pain swallowing. Okay, but they still have some form of dysphagia anyway. Okay, So we start with the reflux esophagitis. This is irritation and inflammation due to reflux of gastric secretion into the esophagus. Remember we said, and we're also going to look at it, the gastric mucosa is, actually is made to make sure that it contains the acid. Any other system in the body cannot contain that acidity. So if that acidity gets in the esophagus will suffer. And that suffering of the esophagus is the reflux esophagitis. And this is caused by decreased lower esophageal tone, or when you have increased abdominal pressure, in that now the stomach is being compressed and the content is being pushed forcefully into the esophagus. So alcohol can do that, tobacco use can do that, obesity, CNS depressants, okay, pregnancy. If you have a delayed gastric emptying, means that there's a lot of food, a lot of content in the stomach. If you have increased gastric volume and even hiatal hernia, I'm going to show you what I mean by hiatal hernia. All this can give you reflux esophagitis or a gastroesophageal reflux disease. Yes. And they normally have a presentation, normally is heartburn or regurgitation. Grossly, when you look at the esophagus, there's hyperemia, there's increased blood flow. And of course, there'll be edema, some form of inflammation. And then the microscopy then be very non-specific. These are diagnoses we do mainly on clinical settings and endoscopy. You see the basal layer becomes hyperplastic, and you can get inflammation of the mucosa, you get neutrophils, sometimes you get eosinophils. But they can complicate, they can still also give you bleeding. When they ulcerate, they can have a stricture, so this ulceration with healing. And the mostly feared sequelae of reflux esophagitis is Barrett esophagus. Because Barrett esophagus is just one step away now from a carcinoma. And Barrett esophagus is a direct consequence of a chronic gastroesophageal reflux disease. It's metaplasia. Metaplasia is a change of a mature adult tissue into another mature adult tissue. We already said that the mucosa of the esophagus is squamous. For it to deal with the acid, the perennial acid being refluxed back into the esophagus, it has to change. And it changes that by now giving you a protective columnar type epithelium with the production of a mucus. Because one of the ways the stomach survives the acidity is by producing mucus by goblet cells. So you change the squamous mucosa to a more protective columnar type. Yes, because of the chronic exposure to gastric secretion. And 10% of patients with chronic GERD will have Barrett esophagus. Normally around male, 40 to 60 years. And normally this leads to dysplasia, Barrett esophagus leads to dysplasia, and eventually esophageal adenocarcinoma. Most of the esophageal adenocarcinomas will be from Barrett esophagus as a form of as underlying sequelae of reflux esophagitis. And if you do screening, 0.2 to 2% of annual patients that you screen for, of patients screened for Barrett esophagus will have some form of adenocarcinoma. So patients, once you make a diagnosis of Barrett esophagus, it basically means you have to continue screening them again and again and again. Okay. Yes, we remember we said this is the normal esophagus, this is the gastroesophageal junction. You can see the mucosas are very different. This is not so velvety, not so mucoid. This one is mucoid. This is the esophagus. This is the stomach. Yes, the stomach. This is the esophagus here. But you can see now here, it looks like the gastric mucosa has moved up. It's now up. It has gone past the gastroesophageal junction. So now you're having what looks more like a velvet mucosa way up into the esophagus. This is a Barrett esophagus. And if you look under the microscope, again, this is the same thing. This is most likely a postmortem specimen. This is an endoscopy. The white patch here is the esophagus, and then this one here is the junction. This should be the normal junction, and this is the excess. This is the excess. They change my color here very fast. This is the excess movement of the columnar type epithelium, so that this esophageal mucosa now can be able to survive the toxicity of the acid content being thrown at it. That is typically the Barrett esophagus. That's a metaplasia. It's the same thing you see in the lung when you smoke a lot. The columnar type epithelium, the respiratory epithelium becomes squamous. And from squamous, you had the squamous dysplasia, and then you have squamous cell carcinoma of the lungs. Yes. Now, when you look under the microscope, this is the stratified squamous epithelium. Yes. And here now is the columnar epithelium. And on top of that, you can see these are what we call goblet cells. This is the intestinal type metaplasia. Intestinal type columnar epithelium with mucin secreting goblet cell. So that now this is the epithelium, and of course there is inflammation, a lot of inflammation in the lamina propria. At this point, we still don't have dysplasia, but this doesn't look very normal already. Yes, so this is a Barrett esophagus. Okay. Now, infectious esophagitis, most of them are Candida. Candida is the most common. Herpes virus and cytomegalovirus, we see them mainly in immunosuppressed. Press the acid so much, you give so many of the PPIs, could be from a carcinoma, could be from corticosteroid use. Diabetes mellitus can do that. Any of these esophageal dysmotility syndromes, gastric surgery, HIV, rheumatic disease, but we tend also to see it a lot even in elderly and very sick patients. We see Candida esophagitis. But you can see it in HIV. Herpes simplex virus and CMV, this tends to be more related to some form of immunosuppression. These two tends to be very more related to immunosuppression. And these are the most common of the infectious immunocompromised patients. They'll have dinophagia, pain when swallowing. Of course, the dysphagia will still be there. They also have esophageal pain because now the esophagus is directly inflamed. And on top of that, you can have herpes with Candida, you can have herpes with CMV, and you can have herpes with the Kaposi sarcoma, especially now in HIV patients. Okay. These white patches now, Candida normally forms white patches. You can see the white patches, and you can see the redness of the esophagus. This is another white patch over here, all this. And of course, there's redness. It's very red mucosa. This is the gastroesophageal junction. This is a very reddened erythematous. The term is erythematous. And on top, now when you look at on the microscope, you see fungal hyphae. See fungal hyphae. These sticks here, these are a fungal hyphoelement in a background of necrosis. This is a Candida esophagitis. Now, for the CMV, they normally have patches of ulcers. There's an ulcer over there, there's an ulcer over here, there's an ulcer over here. And you look at the microscope, CMV basically means a cytomegalovirus. Cyto is a cell, mega is a large thing. So the cell becomes very large. It's a very large cell here. And then it's the nucleus here. and the nucleus has an all eye-like inclusion. This is CMV. Yes, when you see this, we know it's CMV. Okay, the same thing again. Other patches of the esophagus, other small other patches of the esophagus. This is endoscopy. Eosinophilic esophagitis. Patients in the adults, they can present with some food infections or some form of dysphagia. In children, they normally become intolerant to feeding, and they can also develop gut-like symptoms. But eosinophilic esophagitis basically means the esophagus is infiltrated by eosinophils, and the eosinophils could be that spectrum of atopic disorders, the allergic conditions, atopic dermatitis, asthma. Uh, uh, so this could be part of that spectrum. So allergic rhinitis, allergic conjunctivitis, atopic dermatitis, asthma. So this could be the same spectrum of a disease where you have a predominance of eosinophil. So the term we use here is eosinophilic esophagitis. Yes. Eosinophilic esophagitis. These are long rows. There's an ulcer here, and then you have what looks like furrows. Looks like somebody was digging the esophagus. Yes, somebody was digging the esophagus. When you look under the microscope, just take it from me. These are eosinophil, and I think this one you can see. There's an eosinophil there. That's a eosinophil in the certified squamous epithelium. Hiatal hernia basically when you have a distal, when the stomach now goes beyond the diaphragm. The stomach, part of the stomach goes into the thoracic cavity. It's a very common phenomenon. It's normally asymptomatic, usually asymptomatic, but it can give you heartburn. It can also give you reflux esophagitis. And of course, if this is not treated, some of them can complicate, give you ulceration, bleeding, strangulation, can give you paraesophageal hernias, strangulation of paraesophageal hernias. They have increased risk of esophageal and gastric adenocarcinoma because of the reflux with Barrett esophagus and then adenocarcinoma. When a portion, this is the diaphragm. This is normally what we call a sliding. You can see part of the gastric cardia and the part of the fundus has gone past the diaphragm. This is what we call a sliding hernia. And this one you can see only some part of the fundus has gone into the past the diaphragm. This is a rolling hiatal hernia. Very common, very asymptomatic, but the problem is they can strangulate, they can lacerate, they can be exposed to reflux esophagitis. It's basically the same thing. This is a hernia. This is the diaphragm. So part of the stomach has gone into the thoracic cavity. Yes, paraesophageal. Yes, this is the rolling. These are mixed, both the rolling and the sliding. But the whole idea is that part of the stomach has gone into the thoracic cavity, past the diaphragm. Let's review the lesions we have discussed. We have discussed achalasia with the bad big side and the enlarged esophagus. We have discussed sliding hernia. We have discussed rolling hernia. We have seen a Zenker's diverticulum up there. We have seen epinephric diverticulum here. We have seen Mallory waist there. That was the esophagus. The stomach is this. Yes, Julius.
I have two things I would like clarification.
Yes.
I've seen a case of a rolling hiatus hernia,
Mm.
and this patient was the gastroenterologist did endoscopy and he recommended for surgical procedure.
Mm.
The patient is 69 years.
Mm.
So because the main problem is the hyperacidity all the time.
Mm-hmm.
So this gentleman has been on PPIs for some time.
Mm-hmm.
The patient refused
Mm-hmm.
because there was also argument that surgical procedure does not resolve this problem permanently. It can be procedure can be done, but it can also reoccur. So I would like on from whether it's true that it can reoccur or a surgical
Mm-hmm.
procedure can solve the problem permanently. That's
Mm-hmm.
the that's my first case. The second case, there is
Hey.
a female patient of 28 years whom I think I've
Mm-hmm.
I'm at a hospital. It's a
Mm-hmm.
female. It was presenting with when this lady eats green vegetables, they
Mm-hmm.
don't get digested. And
Mm-hmm.
she could feel when the vegetables are moving from through the esophagus, she feels it, and that is very uncomfortable. So when they referred her to a gastroenterologist, they did endoscopy, and they
Mm-hmm.
diagnosed something we call esophageal atrophy. Now, I just want
Esophageal
to know
what?
whether atrophy.
Atrophy
Yes.
or atrophy.
I think they said atrophy. When you're looking at the cell adaptations,
Also, it's
uh,
atrophy.
yes, atrophy, where now the esophagus has a thin mucosa.
Uh-huh.
Therefore, the sensation of the food is very
Uh,
very hard. So I just want to
okay.
know what could be the etiology for such cases. Thank you.
Oh, now for the hernias, we normally do something called fundoplication. Fundoplication means you open and you can do this even laparoscopically. You return back. I don't know, I have a picture here. You try to return this whole of it back and repair the diaphragm, repair that place where the orifice where the stomach was sliding through. But that one can fail. So like now you're having these complications, or there's a possibility that you can have these complications. Surgery might not be the end story for that lesion. Recurrence is there because this could just still get bigger, or the stomach itself could still get weakened and still just squeeze itself and be able to pass, or whatever is causing the increased pressure in the stomach, making it push upward is still there. Like for instance, you have a gastric outlet obstruction here, so that the food content here is a lot and there's some form of a delayed emptying. So I think it will depend. Not all cases are amenable to surgery, and the issue of recurrence is there. Okay. Now, the second question, I'm guessing this could be when they said the esophagus was atrophic. The most likely scenario you are referring to is a stricture. Most likely a stricture. A stricture is when you have atrophy or fibrosis of the muscle wall or even of the mucosa, such that now that part of the stomach has been replaced with some form of fibrosis. The muscle wall has become thin but fibrotic. Yes, and this could be from any other source. In fact, if you remember most of our complications here, you had mentioned the strictures severally. You can say stricture. You can also get stricture from where else do you mention stricture? We mentioned it a lot as a complication to even the gastroesophageal reflux disease and any other disease, including even achalasia. And stricture AS can give you a very severe form of dysphagia, very severe. You can also get stricture if a patient has taken some erosive substances previously, like chemical substances. The best example tends to be acid. If you take acid, a strong acid, there are chances that you won't die. What will happen is that they'll be healing with extensive fibrosis, what we call lytic strictures. So what Zakta you might be referring to here could be some form of a stricture resulting from any of these lesions we have mentioned, or from corrosive substance taken previously, or even from achalasia cardia, or even from reflux esophagitis. And that tends to be a very difficult form of stricture to manage. And the best you can do is maybe try balloon dilatation. If it was possible, these are the ones now we put stents. You push stent, you push looks like a bridge here. You push it when it's very small, then you open it up to actually now open up this strictured or this narrowed esophagus. Because atrophy would be something we diagnose from anatomical point of view or a histopathological point of view. From endoscopy, the best term, you just go and confirm, but that should be a stricture.
So do you have cases where you can put a stent? Because I think this female patient, I think he has been told that he has to live with the condition.
Yes.
The condition cannot be resolved. They put on her some medication that did not give any significant thing for 6 months and did not give any results. So do you have cases where a patient can be stented from maybe from the laryngeal to less esophageal sphincter?
It depends on the location of the stricture. If it is in the upper region, the cervical thorax, stenting is difficult. Mid-thoracic, going to the distal esophagus. Okay, the upper lesions tend to be very difficult to stent, and again, the same follows the same phenomenon of what we do for esophageal carcinomas. Maybe balloon dilatation, but balloon dilatation means you'll have to do that recurrent, you do it repeatedly, because a stricture tends to be something permanent. It's already fibrosed, so even giving treatment there can be, I don't think it's going to do much, because you're not give a muscle relaxant to deal with a fibrotic lesion. So it's a difficult lesion to manage.
Thank you.
And they do complicate that stricture. Stricture is just basically fibrosis from chronic inflammation. Going to deal with the gastritis is the main cause. Minus the carcinoma, we are dealing with the gastritis as the main lesion we have here. We can have congenital disorders, and congenital disorders is basically just one or two. What we have mainly is acute inflammation and ulcers. So acute, chronic, and ulcers. So acute gastritis, chronic gastritis, and the ulcers. So for the main congenital disorder we have is called pyloric stenosis. Pyloric stenosis is when there is the muscle wall of the pylorus is very thick, such that it's obstructing the lumen of the pylorus. And the pylorus, if you remember, you still remember. Yes, this is the pylorus. You can see it here. So if you obstruct, if this muscle becomes very thick, so that this is just muscle, and then this is muscle, then the food will not pass through. So you have obstruction here, so the food collects here, and it dilates, and it dilates, it dilates, and now the food starts going back. Okay, so this patient, this is normally what we call gastric outlet obstruction. In a young child, in a very young child, in a carcinoma causing the blockage. But the term normally we use the gastric outlet obstruction. Yes. So for congenital pyloric stenosis, they are thickening of the muscle wall, of the pylorus. The lumen is completely blocked. Yes. And once you block the lumen, now your patient now starts having what we call vomiting. Non-bilious, meaning that this non-bilious is something to do with the with bile. And bile comes way down from the duodenum. So when you see a bilious vomiting, then it means this obstruction is way down in the small intestine. This obstruction is way up in the stomach. So bile doesn't reflux back to the stomach. So you have a non-bilious projectile because the stomach is actually completely blocked. Yes, completely blocked. So food is coming and just remaining here. So the food remains here. So what you have is the patient feeds. Yes, food remains here, and then all of it is projected out. Yes, so they'll have projectile with frequent demands for refeeding. So they are normally hungry. They vomit, and immediately they want to feed again. So that's normally what you call a hungry vomiter. They want to eat, but nothing is passing through the stomach. All of the food is remaining in the stomach, then they vomit, then they feel hungry again, and then the cycle continues. And because of the recurrent vomiting, they'll be emaciated, they'll be dehydrated, and because they're losing acid, they'll have a metabolic alkalosis. They'll also be losing they're losing hydrochloric acid, so they lose chloride, they lose acid, they have what is called hypochloremic metabolic alkalosis. Yes. And they'll have waves of peristalsis that are visible on the abdomen. There'll be a palpable abdominal mass on the pylorus. The stomach actually becomes thickened and large and very, you can see that peristalsis on the abdominal wall. Okay. Sometimes they can have hyperbilirubinemia. They might have other complications like midgut malrotation. They can have esophageal anesthesia. And then normally the way you treat is you split the pylorus. You split the pylorus from outside. So you split it from outside, meaning you start from the serosa. Yes, this is the thickened wall. This is the mucosa. This is the thickened wall here. Yes, another one here. This is the thickened wall there. So food is not passing through. So what you do is you split the muscle. You split the muscle that you only allow the mucosa. And now food will be able to get sufficient pressure to pass through. Okay, normally what we call Ramsted's pylomyrotomy. And there's normally a dramatic response to this. In fact, you do the procedure and within 6 hours, your baby is feeding well. It's normally curative. This is what we are saying. This is the stomach. This is the pylorus. And you can see the wall of the pylorus is thickened. This is the mucosa. This is the mucosa. This is the duodenum. This is now the stomach. This is the antrum. So food cannot pass through here because of this thickening. You can see the lumen has been narrowed. Yes, this is the congenital pyloric stenosis. And you can do this with an ultrasound. This is the antrum. You can see the antrum over there. This is now the residual lumen of the antrum. It's actually very small. This is the duodenum. This is complete blockage. This is the wall of the pylorus. This is the thickened wall of the pylorus. This is the other thickened wall of the pylorus. And you can just do a simple ultrasound and be able to see it. This is a congenital pyloric stenosis. If you see this kind of pyloric stenosis in an adult, think of a healing gastric ulcer, think of a malignancy. You can have congenital diaphragmatic hernia, basically abdominal content or the peritoneal content has been pushed into the pleura, into the thorax. That is a diaphragmatic hernia because there's a defect in the diaphragm, the herniation of abdominal organs in the thoracic cavity. The most common one tends to be stomach, the most commonly herniated, and sometimes you can have intestinal malrotation. Complication, of course, will be respiratory compromise. This is what we are saying. This is the diaphragm. You can see this is the liver, and the liver has gone through the diaphragm. It's now in the thorax. This is the whole stomach. Most of it has gone. This is the stomach, this is the liver, and you can even see the intestines way up in the thorax. This is a diaphragmatic hernia, congenital, and you can see now the lung has been pushed to one side, the heart has been pushed almost to the right, and this now this area has almost a complete lung collapse. This is congenital diaphragmatic hernia. Meningeal disease, this is when the stomach becomes thickened. So the term normally here we use is the hypertrophic gastropathy. Yes, the stomach rugal folds are markedly enlarged because these patients have an overexpression of a growth factor we call transforming growth factor alpha. They have overproduction of transforming growth factor alpha, which stimulates epidermal growth factor receptor, and these are growth factors that will increase growth of cells. So you have the fovea. The fovea normally is the top layer of the stomach becoming thickened. Okay, and these patients also have decreased acid production because the other cells are not transformed. And because of the cells being weakened, there'll be no there'll be no boundaries. The tight junction that you normally have with the epithelial cell will be lost. So this patient also start losing protein. And because they have diarrhea, they'll have weight loss, and this hyperplasia might affect other cells, other tissues like liver, like the pancreas, and even other GIT organs like the colon will also become thickened. These patients have an increased risk of a gastric carcinoma. It's called Meningeal disease. It's hypertrophic. The rugal folds are markedly enlarged. Before I show you the pictures, another form of hypertrophic gastropathy means there's increased thickening of the layers, of the epithelial layers of the stomach, and this is one called Zollinger-Ellison syndrome. We are going to discuss it again. Remember it when you reach pancreatic neuroendocrine tumors. Yes, so Zollinger-Ellison syndrome is when you have a tumor that is in the pancreas or is outside the stomach producing gastrin. And what gastrin does, gastrin normally increases acid secretion. Gastrin also increases foveolar or gastric epithelial cell hyperplasia. So this patient will have increased acid secretion. On top of that, they have enlarged rugal folds. I'll show you the rugal folds. And these patients, because of the increased acid, they'll have intractable peptic ulcers. They'll have multiple peptic ulcers in the stomach and more so in the duodenum. This is Zollinger-Ellison syndrome because of a autonomous production of gastrin. I don't know whether you can see this. This is the endoscopy. This is a thickened rugae. It looks like the brain. In fact, if I show you this from the top, you will think it's the brain. It's not the brain. This is the stomach with thickened rugae. Very thickened rugae. Very, very thickened rugae. Yes, and even from endoscopy, you are seeing the rugae. These are the very thickened. Under the microscopy, just take it from me. I'm telling you guys, normally don't see these things, but the epithelium looks metaplastic. It looks not metaplastic, hyperplastic. Hyperplastic. not metaplastic, hyperplastic. Yes, hyperplastic. And the same thing here. Compare this rugae, and the way they are sparse here with what you're seeing here. These are very, very many rugae that are tall. It's like you are almost having a hilly environment here. These are thickened rugal folds. Thickened rugal folds, we see them with menetrier disease and also with the Zollinger-Ellison syndrome. And Zollinger-Ellison syndrome, because of overproduction of acid, they also have ulcers, multiple ulcers. And intractable basically means you give PPIs, you give all the H. pylori eradication kits, and the ulcers don't respond because the ulcers are being driven by excess gastrin production, causing excess acid secretion. Okay. What do you see here? Just say whatever comes to your mind first. What do you see here? Anything you see here? There's something, there are two of them. They look like they have taken the shape of the stomach. What could this be? Or you cannot see them very well from your end. It looks like something that has taken the shape of the stomach. It really looks like the stomach. Taken the shape of the stomach. This is just a by the way. It's a rare thing, but it tends to be very, very dramatic if you find it. This is hair. And why should this hair, this is a ball of hair, why should a ball of hair be taking the shape of the stomach? This is somebody who has been eating hair. Who can eat hair? What can happen to make somebody eat hair? Hair is indigestible. The stomach cannot digest hair. Hair has thick keratin. Why should somebody eat hair? And where are they getting the hairs from? Or they're going to the saloons. Yes, I've never heard of this. These are concretions you find. You've heard of guys who sometimes they eat nails, they eat a lot of soil, and then the stomach becomes obstructed, and then the surgeons go in and they find a lot of funny materials in their stomach, and sometimes their rectum, sometimes in their intestine. Yes, this concretion normally is what we call bezoars. Bezoars. So concretion or bezoar formed by hair normally is called trichobezoars. And you eat hair if you have some form of a mental disorder where you like eating hair. If you like eating hair, the term normally we use is a trichotillomania. These are some mental disorder. So this one is just, by the way, these are what we call bezoars. And bezoars. And because it's formed of hair, the term we'll use is a trichobezoars. Trichobezoars. You can see the second, it basically means this stomach was full of this. It has taken the whole shape, a nice shape of the stomach. Now, remember we said the stomach has a very good way of dealing with acid. The acidity here is very, very high. We are talking of a pH that could be higher than your battery, car battery acid. Okay, it's really concentrated hydrochloric acid. So for that, for the stomach to survive, the stomach has a way of dealing with it. And first of all, the stomach has a mucus plug, has these cells that make a mucus plug on top, a surface mucus secretion. Stomach also releases bicarbonate secretion into the mucus to neutralize the acid. They have a very high rate of mucosal blood flow. So the heart hole area is normally just washed every day. A very few minutes, a new supply of blood comes in. They have these tight epithelial barriers to make sure that this acid does not pass through into the wall. Okay, and the epithelium here is very tough. It's replaced every 3 to 5 days. There's epithelial regenerative capability, and then it's replaced every 3 to 5 days. On top of that, you liberate prostaglandins. And that's why you require COX-1, cyclosinase 1, to make the prostaglandins. So that if you give somebody aspirin on when the NSAID, they block the elaboration of prostaglandins. And what happens that you will have a vasoconstriction, you'll have, or you'll shift this to the inflammatory pathway of prostaglandins, not the protective. So you remove the prostacyclins, you move back to the platelet aggregating factors. Okay, so all these are protective factors. On top of that, so that you make sure that the acid does not destroy the stomach. So the esophagus doesn't have this. So the esophagus can easily get destroyed by or damaged by the acidity. So there's gastric acidity you have to deal with, and there are peptic enzymes that you have to deal with. Even the peptic enzymes, those are proteases. Any protein that's there. So you have to be you either have an increased injury or you have a decreased defense. So anything that's going to decrease your defense, and these are the defense protective factors, or anything that's going to worsen this is going to give you some form of damage, increased damage or impaired defenses. You end up with an ulcer, you end up with gastritis, you end up with some form of damage. So H. pylori infection will come to it, NSAIDs, tobacco, alcohol, gastric hyperacidity, and duodenal gastric reflux. All this we can give you increased injury. Or when you have ischemia, you have shock, you have NSAIDs, yes, you will have impaired defenses. And eventually what you end up with there, end up with an ulcer. You end up with some form of damage. An ulcer normally has a necrotic debris there, then you have non-specific acute inflammation, then you have granulation tissue, there are fibrosis. It's basically an active chronic form of inflammation. So anytime you're going to mention some injury to the stomach, one of these factors is wrong. Either you have increased a factor that are going to increase the damage, or they are going to impair the defenses. So the acute inflammation here, we have acute hemorrhagic gastritis. You have acute inflammation, you normally have erosion, you have hemorrhage of the gastric mucosal barrier, okay, or some acid-induced injury. So this is what you get in acute setting. NSAID, alcohol, smoking, surgery, stress ulcers, burns, ischemia, any other stress, uremia, and even chemotherapy gives you acute hemorrhagic gastritis. And these patients have epigastric pain, they can have hemorrhage, they can have hematemesis, they can have melena. This is a blood in stool. Okay. These pinpoint hemorrhages here, you see here, these are acute hemorrhagic gastritis. Those one. And you can even see here a lot of them. Pinpoint look like petechial hemorrhages. I just take it from me. This is histology. This is hemorrhage. Yes, it could be erosive. Erosive means the top layer has been eroded. Erosive gastritis. Okay. And when it becomes so much, you can get an ulcer. Yes, what we call gastric stress ulcers or acute stress ulcers. And they are normally multiple small superficial ulcers of the stomach and duodenum. And what causes them is almost the same as what causes acute hemorrhagic gastritis. Okay? But we see them mainly now with stress. NSAIDs can give you that. Severe stress can give you that. Sepsis will give you decreased blood flow. Shock will give you some form of ischemia. Burns or trauma, normally they increase epinephrine, they increase stress hormones, they increase glucocorticoid. The end result is they have increased vasoconstriction with the decreased blood flow to the gastric mucosa. High in intracranial pressure, Cushing's ulcers, and this again will have some form of abnormal systemic vascular resistance with the vasoconstriction with the decreased vascular flow. We said this blood flow has to be maintained. If you don't maintain it, you will impair the defenses. So any cases that are going to impair that will actually damage it. Very high incidence in ICU patients. ICU patients, again, they're normally very sick patients. Patient with sepsis, patient in shock, a patient with extensive burns, a patient with head trauma. Yes, so this they get what's called stress ulcers or acute ulcers. And the complication mainly is they can bleed. They can actually bleed. And all these are the same thing we are talking about. Or they can ulcerate, but they're normally small and they're multiple. We'll see them that they're different from the typical chronic gastric ulcers. That's the acute. Now, the chronic is when you have persistent mucosal inflammation with mucosal atrophy. And we know that this normally is the start for dysplasia and carcinoma development. The symptoms will be milder but longer lasting. And the most common cause of chronic gastritis is still type B gastritis or Helicobacter pylori infection. You can have others, autoimmune gastritis, 10% of chronic cases. Other causes can be radiation, you can have bioreflux, can have systemic disorders, or even mechanical injury. But the key word here is that these are chronic inflammation. Chronic inflammation. So the first type of chronic gastritis is normally called fundic type, means it's affecting mainly the fundus. Fundic type gastritis or type A gastritis or autoimmune gastritis. In autoimmune gastritis, you have an autoantibody to the parietal cell, and then you have an autoantibody to the intrinsic factor. So if you don't have parietal cells, you don't produce acid. If you don't produce acid, you end up with a chlorhydria, lack of acid. And if you don't have sufficient acid, you don't have parietal cells, you stimulate serum gastrin. So the serum gastrin increases, and this serum gastrin normally causes the antral cells to become hyperplastic. So we have antral G cell hyperplasia. This patient will have pernicious anemia. Pernicious anemia basically is from vitamin B12 deficiency because you need intrinsic factor to absorb vitamin B12. Okay, and what do you find in growth? There will be loss of rugal force in the body and fundus because this is related mainly to the fundus. The antrum is okay. And in the microscopy, there will be mucosal atrophy. We say this is atrophic gastritis. There's lymphoplasmacytic infiltrate because we said this is chronic gastritis. And there'll be sometimes you get intestinal metaplasia because we had said it's normally a substrate for dysplasia and a substrate for metaplasia. That is the autoimmune gastritis. You said around 10%. Most of the chronic gastritis is the antral type. Helicobacter pylori typically prefers the antrum. So you get most of this inflammation in the antrum. So something we call antral predominant. But you can get it even in other forms. You can even get it in the fundus, but this antral predominant chronic gastritis or Helicobacter pylori gastritis or type B chronic gastritis. Depends on which book you are reading. And here now you have both acute inflammation, you have chronic inflammation, you have intestinal metaplasia. And as with all other infections caused by Helicobacter, you have increased risk of a gastric carcinoma. How prevalent is Helicobacter pylori? It's very common. More than half of the world population is infected. And because this infection is a fecal-oral, oral, and even from the environment, we see it in a very high population in areas that have so Africa, of course, normally leads in those areas. So we see it a lot in Africa. North America seems to be doing better. Other countries seem to be having the lowest prevalence. And what makes Helicobacter able to cause this and even survive the acid environment? They're normally motile, so they can move from an area that is hostile to another area. They have a flagella. They produce what's called urease. Urease normally generates ammonia, and ammonia now can counteract the acidity. Okay, it enhances bacterial survival and also inhibits gastric bicarbonate transport. And remember, we need that bicarbonate to counter the low pH that were in there in the stomach. The bacteria cannot be washed off even with food, so they stick around in the stomach because they have adhesins. On top of that, they have toxins, K1 and VAC1 cytotoxins. We'll see where this one fits in. And why do some people get severe Helicobacter pylori, where some people are just carriers, where some people just have it and they are not having a problem, is because of that host pathogen interaction is normally different. The difference in some people having a slightly different interleukin 1 gene and even tumor necrosis factor gene. And because these two are actually the drivers of the chronic inflammation you see in Helicobacter pylori. These are the virulence factors. Okay. These are the tests for Helicobacter diagnosis. You can use antibody, normally in blood. You can use antigen test, normally in stool. You can use urea breath test, normally from a breath sample. You can do bacterial culture from a gastric biopsy. You can do direct bacterial visualization from a gastric biopsy. You can do a DNA-based study from a biopsy from saliva or from stool. So currently the method we can use to diagnose Helicobacter pylori. Okay. This is the stomach. Yes, and the small bluish dots you are seeing, those are plasma cells and lymphocytes. And you can see in this area, it looks like some of the epithelial cells are dying off. So this is atrophy. On top of that, you can see these cells over here. This is what we call intestinal metaplasia. We have goblet cells. Okay, so this is a chronic atrophic gastritis, but this is chronic gastritis. At higher, this one is the cell here. You can now see the plasma cell, but on top of that, now you have neutrophils. So this is an active chronic gastritis. Helicobacter pylori. This is we call it Wathin study. These are silver stain. Silver. Don't worry. Now the chat GPT, you can confirm this very fast. This is a Wathin study. Wathin study. This is a silver stain. And you can see there. You can see the Helicobacter pylori. They normally are not invasive. They are normally just on top of the mucosa. You just find them on top of the mucosa. This is the mucosa. They don't invade. In fact, the damage that Helicobacter pylori gives is not from the invasion. The damage is from the response to the pathogen. Host pathogen, host response to the pathogen is the problem with the Helicobacter pylori. Yes, they are here. This is where they say this is a silver stain. This is called GEMSA. This is called GEMSA stain. This is normally what we use on a gastric biopsy. So what you're seeing here, Helicobacter pylori, numerous. With that, what the microbiologists normally tell you as a seagull appearance. Okay. These are the people the two scientists who discovered H. pylori and the associated carcinoma, and they were given a Nobel Prize for that. So how does Helicobacter pylori normally causes infection? Is by basically what they do is their presence here and the CAG and the VAC, okay, will lead to the attraction of cells, of the inflammatory cells. So the T lymphocytes and the neutrophils will be mobilized. And it's this that's causing the destruction to the mucosa. Yes. And Helicobacter pylori can give you symptomatic gastritis, it can give you an ulcer, it can give you carcinoma, it can give you lymphoma, as you are going to see in your subsequent lectures. Yes. The bacteria normally hides in the mucus and attracts inflammatory cells. So the inflammatory cell, they release toxins, they release all the elastases, they release their cytokine, but they cannot kill the bacteria because the bacteria is way up. It's way up. It's actually outside the environment. Okay, and it's this inflammatory cell that will cause damage by continual ineffective immune response. In a nutshell, that's what happens. So the ulceration, the gastritis, you are having this from the abnormal, ineffective, continual immune response to the bacteria that is way up in the mucus. Okay. They have some genes. They have some genes that gives them what we call virulent factors. The cytotoxin associated with gene A, what's called CAG-A, and the CAG-A pathogenicity island. What they do is they disrupt the tight junctions, they provoke pro-inflammatory, and then they provoke mitogenic. They make the epithelial mucosa regenerate at a much faster rate. And once you have a mitogenic response, basically means there are very high chances that you'll have an error during the DNA transcription. And once you have an error in the DNA transcription, cancer is around the corner. These are just around the corner. Because basically these ones are just abnormalities in the DNA profile. And cytochrome C is a pro-apoptotic factor. You remember the pathway for apoptosis, the cytochrome C and the caspases. And all this now will lead to apoptosis, and you'll have death of the epithelial cells. And when you have death of the epithelial cells, you end up with some atrophy, you end up with some ulceration. Yet induction of what we call transcription factors, nuclear transcription factors, and pro-inflammatory cytokines like interleukin 8. Okay. On top of this, now the reactive oxygen species and the reactive nitrogen species are produced by the the gastric epithelial cells. This also causes more damage. So in short, In a nutshell, this is an abnormal host continual ineffective immune response causing the damage, trying to eradicate the bacteria. When this chronic destruction gets worse, we end up with the ulceration. Ulcers of the distal stomach and the proximal duodenum can be caused by gastric secretion, so increased gastric secretion like HCl or pepsin, and also impaired mucosal defenses. Gastric ulcers tends to be mainly from impaired mucosal defenses. Peptic ulcers tends to be mainly from increased acid secretion. I'm saying mainly. But the etiology, H. pylori is still the main cause, chronic NSAID, steroids, and also smoking. But even COPD, illicit drugs like cocaine, alcoholic cirrhosis, stress basically just increases the stress hormones, the catecholamines and glucocorticoids. And all this will have some form of increase vasomotor tone, and this will decrease blood flow. Zollinger Ellison and even viruses, CMV and HSV can actually damage epithelial cells. And for peptic ulcer, there are complications. They can have hemorrhage. Yes, they can have iron deficiency anemia from the hemorrhage. They can penetrate into adjacent organs. They can have perforation. And sometimes they can heal by scarring to give you pyloric obstruction or the gastric outlet obstruction. Duodenal ulcers are more common than gastric, and they tend to be associated mainly with conditions that are going to increase acid. So H. pylori, rapid gastric emptying, blood group O, this patient has been associated with the increased pepsinogen. Main one is Zollinger Ellison, basically these are production of gastrin with the increased acidity. We see this mainly with the duodenal ulcers. And the classic presentation normally is a burning epigastric pain. Are damaged other than an increased acid because the stomach can deal with an acid. The acid becomes a problem when there's a breach in the defense system. You see it mainly in the lesser curvature of the antrum. They tend to be small, solitary, punched out, overhanging margin with radiating mucosal fold. I'm describing all this so that you can differentiate it from a malignant gastric ulcer. So a gastric ulcer in the stomach, so gastric ulcers can be benign, and that's why I'm using benign. Gastric ulcers can be malignant. So any gastric ulcer has to be biopsied. Duodenal ulcers are normally mostly benign. It's very rare to have a malignant duodenal ulcer. Gastric ulcers can be malignant. So you need to know how the benign one looks, even when you're doing the endoscopy, so that you differentiate it from the malignant one. Again, burning epigastric pain is the typical presentation of the gastric peptic ulcer. This is the stomach again, and you can see now here the rugae are much smaller compared to the others that you're having. Then you have just a single ulcer here. It's punched out. It looks like somebody punched it out. There are no overhanging areas here. You don't see any of the margin, and it's clearly just in one area. What do you mean by punched out? There's no rolling around here. There's no overhanging. There's no overgrowth. If you compare it to the gastric, this is a carcinoma. You can see this one, some edges are coming through, and even the margins are not so clear compared to the other punched out. And again, these are the mucosal folds. So a gastric ulcer has to be biopsied because gastric ulcers can be malignant. Sorry, I've talked for too long. I just want to give you the detailed information on this because not all lesions in the stomach and the esophagus will be carcinomas. But this day and age, you have to do something about anything you suspect in the stomach or in the esophagus. And the easiest is not the barium swallows or anything else. Endoscopy works pretty well. Endoscopy and biopsy will see the whole thing very well. Any question before I come to mine? Mine is very short. Okay, you try mine as we look for others, as we wait for your questions. This one is difficult. Or because of the long stem. Just look for the keywords. This kind of questions look for the keywords. Or I leave you to revise this on your own. Okay. It looks like guys are not interested in this. So I'll let you it's only Timothy who has answered. The rest are afraid. I don't know why they think if they get it wrong, somebody will not. What do you think will happen if you get it wrong now? Get it wrong now so that we correct you. Because at the end of the year, we want you to have known this. Yes, for the sake of time, and for the guys who have answered, thank you. This is pyloric stenosis. And your microphones are on. You can actually just unmute yourself and talk. It's not locked. What about this?
E.
Yes, guitar.
Yes, I'll pick E.
Wanjiku has written D, guitar is saying E. Atobiko is picking E. Polycarp has written E. I'll wait for Rachel. Rachel has picked D. Let me get the final. Mutuma has written E. So let me correct the guys who have answered as D, or I wait for Koech. Koech is E. Chipkimbo is E. Timothy is E. So the E's have it. This one we said alcohol, vomiting, numerous, prolonged vomiting, hematemesis. Now, Wanjiku and Nyambura, D is consistent with Mallory ways because you only get occult blood if you have bleeding after the stomach, meaning bleeding is occurring past the stomach. That's the time you get occult blood in stool. So anything that's occurring in the esophagus and in the stomach, you rarely get blood filtering or even the blood product filtering in the stool. So E is consistent with Mallory. So sorry, D is consistent with Mallory. When you see this is more of an abnormal, this is more of like intestinal obstruction. You don't find this with Mallory ways. So E is inconsistent with Mallory ways.
B is my option.
Yes, guitar.
B, potential for metastasis.
You are choosing B. Priska have chosen C. Any other answer? This is a tricky one. I put it here intentionally so that when you're going to read, you read now finer details. So, Gita, we said gastric peptic ulcer, some of them can be malignant, but not all of them are malignant. So the most characteristic will not be potential for metastasis. Priska, remember we said gastric ulcers are usually due to a defect in the defense. A defect in the defense, not increased acid production, not increased injury. Yes, so this one should be, if you see this, then you're talking mainly of a duodenal. You need to biopsy it because some of them are malignant. Accompanying gastric pancreatic carcinoma, again, you see this mainly with the duodenal ulcers, not gastric. Yes, that leaves with the antral location because that's where the H. pylori is.
Excuse me?
Yes.
Did we talk about the lesser omentum?
Lesser omentum?
Yeah, lesser omentum. We thought I thought I had the gastric that are more likely to occur on the lesser omentum.
Oh, guitar lesser omentum is something different. lesser curvature.
Okay.
The lesser curvature of the stomach. I'll show you the picture at the end. Sorry, guys, it has raised a very clear point that we don't confuse terms. But we can't confuse terms. Without this is the lesser curvature. So this omentum that is attached to lesser curvature is normally what we call the lesser omentum. This piece of fat that is attached to the greater curvature is normally what we call the greater omentum. It's not part of the stomach. It's just that omental tissue attached to the lesser curvature. Is that okay, Peter?
Yes, it's okay. It's okay.
Okay. Again, just look for the keyword. It's antral. There's erythema. So you're also looking at the issue of prevalence.
C. I'll pick C.
So Guitar has chosen C. Coach Bernard is saying C. Bruce and Jerry is saying C. And Tobiko Alan is saying C. That's how you answer these questions. You pick the keywords, and the keyword is most. So it means we're looking at a prevalence of something. And then the erythema here is most likely something with acute inflammation. And among these lists that we have, the only one that's going to give you acute inflammation, and it's common, is a Helicobacter pylori infection. The rest are not. This is a ulcer disease. This is a atrophic gastritis. This is a carcinoma. Will not present with erythema. They most likely present with an ulcer. Crohn's disease is a topically different thing. More for chronic inflammatory process also. I have one more. Yeah, I have one more.
B. My option.
Guitar was chosen B. Any other takers? Marion confirms B. Polycarp confirms B. Millicent also confirms B. Newton also confirmed B. Yes, so it's B. We said that the most common, this is basically what you're describing here, is a Barrett esophagus. And he said the most common cause here of Barrett esophagus is an example of a reflux disease. The last one. This is normal. This is type A. This is type B. this type C, this type D, this type E. I said which is the most common.
Type C.
Yes, Gitawa said type C, Trace is type C. And so guys were listening. Yes, so type C, we say type C, proximal atresia with the distal fistula, this is the most common. So you do that today, but I'm sending the notes. I think I should send them right away. Between now and between your next lecture, you should start discussing. But this is how we ask questions.
Remember the last notes you promised to amend and send, so kindly you can share.
And the one for respiratory infections?
Yes.
Faith has shared. But he didn't get them. If I'm wrong, I'll check again. So these are your practice questions. About a pathology of a lesion, remember, pathology consists of clinical features, pathogenesis, etiology, and morphology. And if it's not specified, your morphology should be for gross and microscopic. Unless you have clearly specified you want gross or you have specified you want microscopic, please just mention both. I'll stop there. Oh, there's another one. No, there's none. That was the outline for esophagus. This was the outline for stomach.